All righty, in the interest of everyone's time, let's get started. Thanks for coming. What a treat it is to be presenting this panel session on managing difficult, distrusting, and demanding patients. This is presented by the Ethics and Professionalism Service of the American Head and Neck Society. It is my honor to be moderating this panel. My name is Alexander Langerman. I'm a head and neck surgeon at Vanderbilt University Medical Center. My esteemed panelists, and really these are incredible folks that we have today who are going to be discussing these cases. So Dr. Elizabeth Cottrell is an associate professor in the Department of Otolaryngology, Head and Neck Surgery at Thomas Jefferson University and the Sidney Kimmel Cancer Center in Philadelphia. She studied philosophy at my stomping grounds, Vanderbilt University, as an undergraduate, earning honors for her senior thesis in medical ethics. She then attended medical school at the University of Arkansas for medical sciences. She completed her residency in otolaryngology at the University of Pennsylvania and pursued a fellowship in advanced head and neck and endocrine surgery at Penn State Hershey Medical Center, after which she joined the faculty at Thomas Jefferson in 2017. During her training, she received multiple awards, including an Alpha Omega Alpha Research Grant and a Core Grant, served her department as Associate Program Director of the residency since 2019, and she focuses on developing educational and wellness resources, and was recently selected to receive the Faculty Award for Teaching from the Sidney Kimmel Medical College. Really an incredible person. Her practice spans both the urban main campus hub and the community-based Jefferson Northeast campus, where she serves as division chief and on the medical executive committee. Her research focus is benign and malignant neoplasms of the thyroid and parathyroid, and she serves as co-director of the Jefferson Thyroid and Parathyroid Center, and of course, is on the Ethics and Professionalism Service of the American Head and Neck Society. Dr. Roque, Daniel Roque, attended medical school at the University of Michigan after completing his law degree at Duke University. Very important member of an ethics committee is always to have the legal representation. He trained in residency at Duke University Medical Center, received advanced head and neck oncology training at the University of Toronto. He currently works at Duke University, where he specializes in surgical treatment of thyroid and parathyroid disorders. And then last but not least, Trevor Hackman is a professor of otolaryngology, head and neck surgery, and serves as the division chief of head and neck oncology, fellowship director and vice chair of inpatient quality and operations at the University of North Carolina at Chapel Hill. Having been on faculty since 2009, his clinical interests include head and neck oncology, minimally invasive surgery, silent endoscopy, salivary surgery, and reconstructive surgery. His research interest spans translational cancer research, clinical trial, induction therapy models, QI research, and epidemiology. Within the AHNS, he has many roles. He serves on the executive committee for the salivary gland section and is a member of the mucosal service, the ethics and professionalism service, and the reconstructive committee. So thank you three for coming today. The way we're going to do this is I'm going to make a brief kind of overview of the concept that we're talking about today, and then we're going to have a few cases to discuss. Now, one of the things I just want to say right off the bat is we really want some audience participation. There's a Q&A section. There's the chat. Please feel free to post questions or thoughts. We're going to work those into the webinar. And also, some of you may have seen the invitation to bring your own cases. And if you post your cases in the Q&A or chat, we'll be happy to work those in and have a discussion around that as well. So your challenging patient cases. Excuse me. Sorry. This was kind of cool. I found this Terry Day's AHNS presidential address in New York at the international meeting in 2014. He concludes with saying, "We will all look to a physician one day for answers, for assurance, for guidance, and for truth." I'm sorry. And in that moment of need, our physicians must offer honesty, trust, and healing. And hopefully they will give us what we give our patients today, a strong physician-patient relationship. Don't forget about this bond each of us has in this room with our patients. It is what sets our specialty apart. And what Terry Day was talking about throughout this talk, the history of the surgeon-patient relationship, the history of medicine, it was a glorious talk that covered many different aspects of our specialty, was that he quoted Dr. Shah in saying, that our specialty is unique, that we care for the disease and the patient with the disease. This is a horrible disease that we treat for many of our patients. Cancer, life-threatening, changes their quality of life, their appearance, the way they experience everyday existence. And that connection with our patients is so important, and that we need to provide them with that trust and that empathetic care. So what are the challenges to the surgeon-patient relationship? And there, we could have a whole talk about the modern challenges of the electronic medical record and the distractions and the poor reimbursement and the many pressures that we have. But zoning in on the idea of the difficult doctor-patient encounter. And what we're talking about here is that small percentage of our clinic encounters, hopefully small, right, where we have a really challenging patient. You just walk out of the room and you say, man, that did not go well, or this left me with a bad feeling. And we say, okay, what are the causes of that? So, well, first of all, there's, these patient factors, and some of them are part and parcel of the disease we treat. There's fear, the fear of their death or a terrible change that's going to overcome them. There can be anger about that as well. If you think about the stages of grieving. Some patients will come in with prior negative experiences. In my own research, that was a huge factor in patients who were uncomfortable with trainees being involved in their care, was that they had a prior negative experience with the healthcare system. And so we need to be aware that might be an underlying cause of some people's approach to the surgeon-patient relationship from a patient standpoint. There's the financial stresses of major medical diagnosis. There are, medical literacy difficulties. There's also potentially actual diagnoses, mood or personality disorders. You can have borderline or dependent personality disorders that particularly obstruct the physician-patient relationship. You can have manipulative patients or overly entitled patients. And we'll talk about some of these in this webinar. For surgeons, many of us are under stress, and emotional burnout is something that we talk about all the time. We had a wonderful AHNS ethics and professionalism webinar about this just a couple months ago. There's fatigue, right? You didn't get sleep the night before, or you're just working really hard up super late and seeing patients at the end of the day. You might feel overworked. You might be running late in clinic and feel the same urgency on top of the patient, being angry that you're running late, or having an enormous problem that needs a lot of time to deal with. We can also be victims of our own cognitive bias, right? So, we don't think that this disease is a real problem, or we don't see the actual disease that's going on or the actual problem. We haven't rooted it out. A failure in some ways of our ability to be a doctor. We could also have negative bias against certain diseases. We could not know enough about those diseases, or we could just be jerks. We could be an arrogant person who's feeling like the patient's stupid. I hope that's nobody on this webinar. Obviously, if you checked into this, you're probably a good person thinking about how to be a better doctor. But the reality is that can happen, right? That you can have your own moments of a failure. And then lastly, there's these contextual factors. So again, getting back to head and neck surgical oncology, bad news, the time pressures of clinic, the chaotic environment, getting multiple labs done, arranging tests, other things. You have, students and residents in clinic. It can be a stressful thing for the patient, as well as families can sometimes have a negative effect on the surgeon-patient relationship. Patients may come in with sort of half-informed or misinformed knowledge from Dr. Google. And then, of course, there may be language barriers or cultural differences. So with all that background, I now, once again, remind the audience, if you have cases, please start posting them in. We'd love to see those. And we're going to start with Dr. Cottrell's first, is going to present our first case. So take it away.
All right. So you are set to see a 55-year-old male who presents to your clinic for evaluation of an incidental thyroid nodule that was found on an MRI done for persistent neck pain after he underwent an ACDF. Your nurse, as she's giving you the chart or walking towards your sit-down space, says, just a heads up, he gave the front desk a hard time when they provided him with a mask, shouting at them and saying, I'm not sick, and they lifted the muzzle mandate for the city. I don't need to wear this. Your nurse also alerts you that the patient did not bring the disc for his MRI images, and he became really angry when she asked for them because he expected that you had already received him from his spine surgeon. On your initial introduction, the patient begins with, I don't really know why I'm here, but I guess I already paid the copay to see you. And then adds, by the way, your office is impossible to find. So with that, my colleagues, how do you begin? You haven't even opened your mouth yet, right? You walk into this patient's room. How do you begin this encounter? Is there any graceful way to do this?
I love this patient. This patient brings a smile to me because I get this patient at least 2 or 3 times a day, and hopefully I'm not an hour behind by the time I see them, because that just makes it worse. But my first response is always to say, "Okay, well, let's figure out how we can help you here. You're here. Let's figure out how we can help you." And then I go to questions like, "I know you're here about your thyroid, but has that ever bothered you before? Can you tell me a little bit about it?" And if they are wearing anything, any kind of, like, even though I'm at UNC, at NC State hat, I try to bring some sort of contextual reference into who they are, and something to kind of bond with them. And so if they have something they're wearing, I'm like, "Oh, you're a Patriots fan? Oh, I'm a Steelers fan." Something that gets them to kind of humanize. Those are my 2 tricks to try to get them to kind of break the ice. Sometimes they're still hard nuts to crack, but that's usually where I start.
It's a great place to start.
You're not the only one that sees these patients, Trevor. They probably come from me straight to you, though. Yeah, I mean, I think there are ways to disarm these patients a little bit, and apologizing for the things that they're having trouble with. I think there's usually something behind these patients too, an anxiety or something. I mean, they're coming in with something that's driving this, and it's hard to get out at that initially, I think. But I think as the appointment progresses, there's sometimes ways that you can say things like, "You seem anxious," or ways to sort of disarm them a little bit. But it's hard because they come in guns a-blazing, and it's easy to, if you come in with the same attitude, that really makes the encounter difficult, I think.
Yeah, I'd add in, it's tempting to be like, throw the other surgeon under the bus. Like, "Yeah, I don't know why they didn't send that scan," but that never goes over well. And so it's like, it's easy to be like, "Yeah, I know I don't know why that practice doesn't do that." And that's an easy thing to do, but I would hesitate. And the fellows that are on the call, don't throw another surgeon under the bus or another physician under the bus. It's a scapegoat. You can just say, "Listen, we'll figure it out. I can still see you. We can still talk about all of this. I've got an ultrasound in my office. We can check your thyroid, so we can work past the fact the scan's on here. Don't worry about it. We'll make that work." And reassure them they're going to make it work, but try to not inflame their ability to play the blame game, because you don't want them going to another doctor and someone else doing that to you. So steer away from that as much as possible, even if the patient is trying to steer you there.
Yeah, agreed. I think that karma is only ever going to come back someday. Yeah, I think especially, I know you all practice in different places than me, but in a very litigious place like Philadelphia, it's definitely something that you see it, that, "Oh, well, this person said I should have gotten X, Y, or Z instead of LMNOP," and there you go, it's a lawsuit, and you're finding yourself in a difficult situation. But yeah, I try really hard to kind of steer away from that as much as possible. And just kind of taking it that one step back. I think similar to the way I respond to my 4-year-old when things are not going his way, it's kind of like, take it down one notch. Everything's going to be okay. And sort of proceeding with, like, I can be flexible so you can be comfortable, and yeah, letting them know our office can take care of that, or we can help figure that out. Yeah. Alex, anything else that you would add?
Well, I mean, a couple things. Yeah, I really think the responses are wonderful. So the person you describe, in some ways, it's a flex, right? They're trying to gain some control over the situation. They're trying to grab theirs and show that they are powerful. And sometimes treating them like they're powerful is really helpful. Be like, "Oh, gosh, I am so sorry that there was challenge, but we are here to help you. We're here to help you, sir, and we're gonna figure this out." Although I think that the other thing that it's funny. I see some ordinary patients, of course, too, right? We all do, but I have a couple patients that stick out of my head who are really bad. Really bad, verbally abusive people who, for various, sort of problems. And I think it's important at times to recognize when there is an outlier, And I had like, for instance, I had a patient who was so incredibly rude to my nursing staff. It's like, you can be sort of a jerk to me, but don't be a jerk to the intake people and the nursing staff and whatever. And but was consistently so. I mean, to the point where my wonderful, dedicated, super caring nurses were like, this guy is bad news. Like, it was so incredibly rude to me. And I did approach him about that, after, sort of down the road, right after a couple of encounters when it was consistent, and we tried all the other things. And I said, man, it's important to me. You can be however you want to me, but it's important that you don't treat the staff this way. And he got, not surprisingly, really upset, at that suggestion, and implied that it was my nurses, and it's like, well, I work with my nurses every day and they don't tell me this about most patients. So there might be something there. Let's work through it. How can we figure out a way to work through it? So sometimes you do have to confront people, not like coming out of the gates, but if there's a consistent pattern of real serious abusive, it is okay and acceptable to talk about that with them and try to find a path forward, or check them, at their behavior.
I totally agree. It's like Alex put in that first slide. There's some people who have left a partner and come to see me or somebody else, and they've been labeled as difficult. But what they are is like, it's either they're difficult, the family's difficult, but it's not that they're difficult. They're just really scared and they're trying to advocate the best they can for their family. And they just don't want to feel like they are not being listened to. And so that's one difficult patient who wants to feel that they're being heard and listened to. And you'll sit down and take the extra time to talk to them, and you'll respect their concerns and their wishes. But then there's a difficult patient who is just bullying and abusive behavior, and setting expectations and boundaries early on I agree with Alex, is critical, because those are two different types of difficult patients, and they're not all handled the same. And those are the ones that you got to just say, listen, there's a boundary line that you are crossing, and I will be willing to give you care, but you cannot cross this boundary. It's a deal breaker. And I think you have to, like Alex said, you have to stand up for your staff for that. But it can be tough to figure out in that first encounter, are they motivated by fear, or are they really somebody who is going to be a boundary patient? And that's something you figure out over visits. But setting that boundary is key, because your staff shouldn't have to bear the brunt of it. And classically, they will be super rude to the staff, but they'll be fine to you. And that's the worst, right? Is that they'll be super rude to the staff. And so you have to kind of call them on it, because they can play that game.
Yeah. I'm going to go on because I think most of the points.
Oh, can I just,
more.
Beth, there's a couple of comments here that I think are germane here. So just to add into this discussion right now, what are some good ways to show the staff you support them in the scenario of the angry staff? And I'll open that up to anybody here. Maybe Beth, if you want to start.
Yeah, I think honestly, just talking to them directly about, the staff, that is, about, the ways in which you're supporting them. But I think also, especially if my nurse is in the room with me, them hearing the way that I'm interacting with the patient, but then also sticking up for them, it's not my nurse's fault that CT scan wasn't obtained or whatever, but hey, you know what, she's amazing at sleuthing, and she'll contact at X, Y, and Z office. We always are able to get that. And so kind of in other words, like coming to their defense, and then also actually saying like, and they're a critical part of this team that's going to make this treatment work, so that it not just, shows them you've got their back, but also lets the patient know that like this person is important right here. This is somebody that's key to this whole thing working, not just the surgeon, just kind of what you were saying about, classically being, nice to you, but mean to your staff. Well, if they understood how important our staff are to what their care actually is, I think that can change things.
Yeah, I think trying to take responsibility for what, and apologizing for what's happened, and sort of taking the attitude that, whatever has happened to you, that's on me. And because this is, it's my office and my staff, and, just sort of having that sort of leadership role where, ultimately I'm the one responsible, and you can talk to me about any of the problems you're having, but it's really on me. It's not on my staff.
It's always good. Add in one other thing from the Q&A here, and then we'll move along. But Margaret Mitchell brought a great case in that I'll summarize. Is now you have the same kind of scenario, but it's a post-op patient, and they're in the hospital and they're belittling staff. They're threatening to destroy team members' careers, refusing care from certain team members. And so how do you handle, is there anything different considerations when they're not walking into clinic, but you actually, you have them in the inpatient wards?
Yeah, I was reading that case, Margaret. This is a really tough one because this one really affects the fellows and the residents, because they're the ones that are rounding like every day on these patients who can do this. Number one, I think it's very important that the attending is present, and that the attending sets a ground rule saying, and basically telling them this behavior is not going to be tolerated, and that we're providing you care, and this is necessary care. If you don't want to have care in this hospital, which you desperately need for you to have your best possible outcome, then that means leaving against medical advice. If you want us to provide care for you, this is what you signed up for, and this team is trained to take care of you. And I think in the scenario she brought up that they had to have security with them, we've had a few patients in the hospital who are like this, where we had to actually have the behavioral response team come by and help manage difficult or combative patients, involve psychiatry in seeing these patients and saying, listen, and then we even had one time where we actually had the president of the hospital come down and say, this is our institution, our staff are here to take care of you. And right now, what you're doing is akin to assault and battery, and you need to stop and desist if we're going to take care of you at this institution. And so you basically have to escalate it. The residents and the fellows and the nursing staff should not have to deal with the verbal or physical abuse from a patient in the post-op scenario. The attendings to get involved, behavioral response, patient relations, and even escalating it to leadership in your hospital, because it's a safety issue. And these patients need to understand that the authority and the weight of the hospital is backing the people who are taking care of them.
Like that. Yeah. I mean, because you own them. You messed them up, and now you kind of get them better, right? But I like the idea of aligning their interests, getting well, with a behavior change that maybe would get them, helping them understand that'll get what they want better. But that's great. Yes, let's move on.
Right. So I think we really honestly hit most of the points that I wanted to bring up with regards to kind of how to address this in our discussion. So, the first thing is just trying to remember that this patient is suffering and they're in a place of vulnerability. I think those themes came up in multiple of the things that the panelists discussed. Even if the suffering is not something you caused, maybe it is in the post-op scenario, but maybe the suffering is actually something that you're not really aware of. Maybe it's a divorce that they're going through. Maybe it's a financial hardship. Maybe it's something that has to do with another type of medical scenario that they're in. Again, in an incidental thyroid nodule found after an ACDF, that they're having still persistent pain. Physical pain physical suffering is quite likely in this patient. But there are all sorts of different kinds of suffering, and kind of aligning yourself mentally with the fact that as the motto of the AOA, we are to be worthy to serve the suffering. That's kind of where we have to begin a conversation with somebody that we don't initially have a reference point of connection and trust. Is sort of finding that moment where you can say, okay, this patient is suffering and I need to get myself to that, acceptance so that I can begin to build that. And it's a tough place sometimes when you feel personally threatened or you feel the instinct to become defensive. So beginning there. And the second is that place of vulnerability, as you were saying, Alex. They were trying to kind of flex, like, if it's, they're in this place of, and especially in the post-op, space, like they're in the hospital, they're in a gown, they're half naked sitting in bed, and they've got, stitches and blood and all of these things. They're in a place of severe vulnerability. And especially, for example, in that patient scenario that was posted, these are patients who are not used to and not okay with being in that place of vulnerability. And maybe they're okay with it, and they're mentally okay with it in your hands, in your office, in that safe space. But sometimes becoming the inpatient that then has a cadre of residents and medical students and fellows and things that are rounding on them, and sort of being in that place of vulnerability to the extreme is something that they're not able to handle. So kind of, first of all, I guess the mindset as we go into it, you can advance. And then the second one, I think everybody brought up as well. I think especially Trevor, brought up setting boundaries. I think both for yourself, many of us, the initial, reaction may be to become defensive, especially if somebody does seem like they're, bashing your staff or bashing, something about your practice. Try not to immediately take that defensive stance, but actually try and hear their concerns, try and connect with them. I love the idea of, they're wearing a sports team or, something like that, that you can kind of begin to sort of have that relationship with them. I love it when I see a patient in Philadelphia with something from West Virginia on, because immediately I can make a very rare connection with that patient. That is really truly personal. And same thing if, wherever you are, if there's something that kind of reminds you of something, you've got that tiny little piece of their mind where they think, okay, I can trust this person. I can listen this, to this scenario. I can hear this patient or this person out, this physician out. And then setting those boundaries on the other side for the patient. And I think multiple of you kind of mentioned this specifically, is having that team that's maybe coming in to help when this inpatient is getting too frankly aggressive, or standing up for your staff, saying, hey, as Dan said, you can put this on me. This is my staff in my office, and if there's a problem, the problem is mine to I'm the person you can talk to about that. I think all of those things really are, kind of the framework in which we can begin to make inroads and see these patients and actually give them the care that they need.
That's great. We're going to move on to the next scenario here. So thank you, Dr. Cottrell, for that excellent discussion. So Dr. Roque.
Yeah, thanks. So this patient, I had this patient like a couple months ago. So I feel like hopefully this is real, because it was pretty real for me. 65-year-old guy comes to your clinic for his advanced oral cavity squamous cell carcinoma. And you recommend that he get a PET scan and ask him to follow up after completion of the scan. And he throughout your encounter doesn't maintain eye contact with you. He appears annoyed at your questions. He's very difficult to engage. This particular guy that I saw mumbled a lot, was non-committal in his responses. He misses his next follow-up appointment and finally returns a month later after skipping his PET CT. And I don't know if it comes through in this particular scenario the way that it did in person, but trying to paint a picture of somebody who just doesn't really trust the medical system. And you can advance on to the next slide there, Alex. But just I think some questions for the panelists here. How do we explore this this lack of trust with that you're getting from this patient?
Yeah, I mean, I think finding out what drives that lack of trust, and maybe let me back up. Starting with, and I think you said these words, right? Didn't really trust the medical system. Is that, I mean, there may be they may not trust like you as an individual. Like a patient may look at you for some reason and not trust you because of something you said, because of some behavior you have, because of differences in cultural background, that make that its own challenge. But many patients who come and they simply just don't trust doctors, right? They don't trust the medical system, as you said. And so then, it's recognizing it's not like an insult to you personally, but rather that there's something behind it that that led them to that feeling, whether it was their wife. How many patients have we had where they say, their wife, had, or their mother had chemo, right, and it didn't work, and they died a horrible death, or something where they've just had a really terrible experience to the point where they don't think that doctors are necessarily out for their best interests, or hospitals, or that alternatively that there's any hope of success. And so that, digging into that a little bit, and even just asking simple questions like, it doesn't seem like you really want to, you want to be here. What's going on? What have you had? What other medical experiences have you had? What other diseases have you had? Have you ever had to be cared for anything else? Any family members? And exploring that in a way that takes time, and you got to do a lot of listening, but can often reveal some bias based on that.
Yeah, I really wanted two scenarios, because I feel like when I was thinking about this, there's I sort of thought of two different types of people who wouldn't trust you. And there's the people who come in, as you were saying, Alex, just not trusting the medical system, or we've had some bad experience. I think about, there's a substantial poor African-American population in Durham, and that, that population has been, taken advantage of in the past by the medical system. And so understandably, there's distrust there. And, I think you have to engage people in that situation maybe differently than the other type, which I was thinking of, is the people who tend to be on the opposite end of like the socioeconomic spectrum, who may not trust you because they did some research and they're just, so I feel like there are two potential ways you could look at the situation, which I think are both really interesting, and you probably have to approach the two differently.
Like the I know better patient. Yeah.
The guy who comes in with the 6 studies that he wants you to comment on, and what about this study, and what about, you said this, and I Googled this, and I mean, that type of exhausting encounter, I think that's a different animal than this particular patient, who I think you were hitting on. You're exactly right. Just like a lack of trust that things could get better, or that we're really looking out for his best interests.
Yeah, these patient stuff, especially the patients that don't give you eye contact, those are super tough to read, right? And the lack of eye contact is definitely a telltale that this is going to be a long visit. It's like, tell your nurse that you might not be out for a while. Those patients who don't want to talk and they seem distrustful, I usually go with, especially like tongue cancer, like, how are you eating these days? Are you able to eat? That's got to be really painful. And tell them, my job honestly is to see if I can make your quality of life better. I know it's got to hurt, that cancer, and I'm sure you're miserable right now. So we can talk a little bit about sort of what's going on there. And my goal is to hopefully try to get you to where you're not only as a cancer removed, but you're able back to be eating and talking and not being in pain constantly. I'm sure being in pain constantly is exhausting, and trying to get at them, like, what's bothering you. And my job is to try to improve the things that are bothering you and get them to kind of focus on, yeah, this really hurts. I'm like, I'm sure it hurts. And then you might get up, well, somebody else biased this before and told me when there was nothing wrong, and now this is going on. And then you might get that story. But I usually will start to say, well, like, trying to probe them, like, something's got to be bothering, that's got to be hurting, and get them to at least say, yeah, that's hurting. Like, oh, can we talk about how we can maybe make that not hurt? And here's what I would offer. And then in the distrustful patient, like you're mentioning, like, listen, you don't have a ton of time because you had a cancer, but if you want to get a second opinion, I have some people I can send you to. And then you kind of say, you know what, listen, I'm giving you my medical advice, and I'm not only giving it to you, but I'm saying that I am confident enough in my medical advice here's the names of a few other people if you want to go talk and get their opinion too. I'm not hiding anything. This is what I would do, but here, if you want to go see these folks, here's who you can go see, and give them that that out, that they can take your advice, but also know that you're not trying to like lure them in, if you will.
Yeah, anytime anyone asks me if they should get a second opinion, I'm like, please,
Yeah, go for
I
it.
would love that. And if they say something differently than me, tell me. I
Yeah.
want to know, I want to know if they're going to do something different, because that's important for your care, so yeah.
I think these patients are, I mean, some of these scenarios I feel like that we brought up, I think you can sort of try to address them head on, in the sense of like, why are you feeling this? But I feel like this particular type of patient, you really have to almost approach obliquely. You can't get to the source sometimes of what's causing them to distrust the system. And that,
and to go back to
patient,
go back to the
way you were going to be able to get to that point with him.
Sorry, yeah, my audio went off a second. To go back to the Q&A question, this is the patient that Dan's presenting, that then in the hospital becomes the patient we just talked about, the Q&A question, where the patient's now being combative, because most conflict arises out of failed expectation. So when you have the distrustful patient in the clinic and you don't spend enough time going through, here's what to expect. The patient who's in the hospital that we talked about, the Q&A post, that was a really good one from Margaret. There's at that time, you've got a flex authority behind you. If you're the resident fellow, get the attendings and the hospital staff there. But then what you need to do in the background is, how did we get here? And how we probably got there is that patient probably wasn't prepared enough to be in the hospital, and maybe their expectations of what was going to happen weren't set very well. So you have to sort of step back and say, what could I have done next time so that we don't get to this scenario? And this distrustful patient, if you don't tell them everything to expect, and then they go to the hospital and then something doesn't go the way that they expected, but it's what you expected, then that trust is lost. And so you have to pretty much spend a lot of time. And this is where, if your hospital invests in sort of patient information and access to instructions and that kind of stuff, the more volume of patient material you can get them to read and go over, and then the more that you reinforce that multiple times, the better. These tough patients, if you see them once in clinic and you operate on them 4 weeks later and they don't remember what you said, and all of a sudden they're going to say, but you didn't say this, you got to have, the more information you have written down for them, the better, because they're going to come back and be very difficult in the hospital if they're already distrustful in the clinic.
So self-fulfilling prophecy. I love that. That's a really good point.
I liked what you said earlier, Trevor, too, about just asking the questions that let you know that you care about them. Because I think a lot of these patients come in and they think we feel like this is exactly the type of person who a little bit down the line is going to ask me how much I make off of the operation, that kind of question. Yeah. And, I think those questions that you were suggesting, I think are great, because they're questions that should indicate to the patient that you care about them and you want to help them, and you're asking questions about things that are important to them. And I think that's the way you get through, at least to the type of patient who just doesn't trust doctors or the medical system. They just need to know that you're a person and you care about them.
The other thing I'll just mention is, when you have a patient who's avoiding eye contact enclosed, another thing that should come in your head is abuse. Someone who's being abused will act in that manner as well. It's ultimately a much different scenario, but may present in the same way, as sort of distrustful, detached, and enclosed in their body language. Dan, I'll let you get on to your overview as we're moving along in this webinar. It's going quick.
Yeah. I won't take up too much time here, because I think we hit a lot of the points. But if you look at some of the people who study this, more specifically than probably most of us do, a lot of just reports of Americans not trusting physicians, at least in the same way that they used to. A lot of different theories as to why that could be. And I won't go through these. I think we've kind of hit them. Maybe go on to the next slide though. When we think about ways of improving trust, I think this kind of hits on the two different types of patients that might not trust you that I was talking about earlier. And I think you really have to start with I think we hit these points like openness to seeking a second opinion and asking questions that show that you're compassionate and that you really do care about what bothers the patient and what impacts their quality of life, and talk to them openly about those things and what you can offer and what you can't. I mean, there are all sorts of other things that may help with that patient who may not trust you because they think they know better. And that I think is some of these other things, like it's just like stuff from your CV that show that you're engaged in the community, engaged in advancing the profession. And I don't honestly know how much the peer review and credentialing process help with all that, and nobody's ever asked about my CME, but just the things that might help just from a external person looking in, they're more system things. Does UNC credential Trevor to do this? I guess maybe that adds something, but the thing I think that is most important is just that openness, honesty, maybe even vulnerability from our standpoint of like, yeah, please get a second opinion. And yeah, as you said, Alex, let me know if it's different than what I told you. I think that goes a long way.
Yeah, and before going, the distrustful patient, like I think, like Dan said, you're not going to win them over in the first clinic visit. So these are patients that a follow-up phone call before the surgery and some touching base afterwards can go a long way to kind of breaking the ice, because it's hard to break the ice in just one clinic visit. So taking like 10 minutes out of your day, like 4 days later, to follow up with them. Hey, do you have any more questions? I want to go over a visit. Make sure you understand what we're doing. That can go a long way to really helping you. It helps with all patients, but especially the distrustful ones. So here's our third scenario, the demanding
and
patient.
I'll notice in honor, Trevor, of our demanding patient scenario, it's 3 slides worth of scenario. It's a long scenario. So
oh my gosh. So yeah, it's a long scenario. So we've all had the demanding patients, the SIP, self-important patients, the ones that light up your in basket, call your nurse 5 times a day, expect results right away, see you in clinic and want surgery a day later, don't understand why they have to wait, like, and they basically are trying to bulldoze you as a physician. They're the ones that call you by your first name, and expect sort of like to have that power struggle that I was talking about. So here you are, an hour after being efficient, you advise the patient your recommendations for physical therapy and decline to recommend surgery. You're a surgeon, you're like, I don't think surgery is the right option. The patient requests pain medication leash. You offer a muscle relaxant because you're like, I don't think you need narcotics for this. You try to explain the opioid epidemic and everything else. You offer muscle relaxants and physical therapy. And the patient leaves upset that you wasted their time and did not help them. Following the visit, the patient starts to send messages to you and your nurse, sorry about the typo, and your nurse in Epic with photos of the neck and a still shot images of the CT again, saying, see this spot right here on the CT? This is really what's bothering me. I need pain medication. I need surgery for this right away. You respond with a reminder of muscle relaxant and physical therapy. So I'm going to stop there before we go on. I'm sure we've all had patients similar to this. So this person comes to your office. I guess, Elizabeth, Dan, what do you do?
I feel like this is half my clinic. Yeah, I think, and I don't know. I mean, this is just my own experience. Y'all can tell me if I may be completely blowing this, but I think what I do is I go in and try to set the expectations of what I can provide as a surgeon, and maybe I'm just kicking the can down to somebody else, but I like to emphasize, look, here's what I can tell you. I'm a surgeon, and surgery is not going to help you. And I emphasize things like, look, the CT images show that there's nothing structurally wrong. I mean, really, I feel like I see this like 15 times a year at least. I mean, it's just, but I think it's helpful for patients because I think when you say, hey, look, the bad news is I can't tell you what's wrong, but the good news is I can tell you that these it's not cancer. I feel like some people actually come in and I sometimes ask them, like, what are you concerned? Like, are you concerned it's cancer? So a lot of people come in and that's what they want to know ultimately. And I think your scenario is getting at something a little bit different. And I may punt that one to Beth, but I think I'm trying to set expectations as to what I can provide, like right at the outset, I think is helpful, because it sort of boxes them in a little bit about what we're going to talk about and narrows the scope sometimes. I mean, it's not foolproof, but it's worked sometimes, at least for me.
I think going off of what you were just saying, Dan, it really is sometimes about kind of finding, what do you think it might be? Like sometimes that's like a key question that, may lead you in a type of explanation that is more helpful, or that the patient is able to hear a little bit better. Just saying like there's nothing there sometimes is just like not acceptable, even to pretty reasonable patients, because they want to know, well, why am I having this sensation? And I think that also taking that aspect of like, the what I can actually tell you based on these images and what I can't tell you based on these images, or what I can tell you based on your exam and what I can't tell you based on your exam, sometimes is helpful. And I don't think, for as much as it may seem like kicking the can down the road, I don't think that this is a bad place to also offer a second opinion. Like, hey, I'm just one person. Maybe I'm getting this wrong. I think I've, looked at a lot of things thoroughly, but I'm, certainly just a human being. And I would be, very, encouraging of you seeing, some other kind of provider, and maybe not even another ENT. Maybe we say, let's set you up with neurology or something like that, to kind of do something else that is a little bit different, especially if there's a leaning of the patient. Maybe that's a little bit, just kind of, again, kicking the can down the road. But I don't think that there's anything wrong in kind of admitting that there are things that we're just not going to be able to tell them, and surgery is not going to be able to fix.
Yeah,
I will often tell patients that come with these sorts of issues that I'm so glad they came in. That I'm glad we had a chance to talk through it and rule out some important things.
Right.
Which I think rolls off what was just said, but I do like really encouraging them. What I often tell my residents is, the last thing you want is for that patient to walk out of that visit and feel like it was low value service. Now, Trevor, admittedly, you're creating a scenario where like you're probably doing all those things and they're still demanding, and we'll move on with it. But it is important to let patients know that that you felt like there was some value, and make sure that they feel like there was some value out of the encounter.
Yeah, like to quote like I forget the movie, but it's like the greatest trick that the doctor pulled was having the patient leave the clinic visit doing nothing for them and having them thank you for it. And the only way you do that is, number one, getting to what Dan and Beth and Andrew are saying, is getting them to first of all, it's empathizing with them. That I understand you're in pain. Like I'm not dismissing it. You don't want to be dismissive. You don't look at them and say, "Oh, you're not an operative case. I need to get them out of the room so I can get to the next room." So not being dismissive and not appearing to be dismissive, empathizing with them, saying, "I hear you, but if I operate on you and I'm operating on nothing, I'm probably going to not make that symptom better. And I'm going to give you more." And sort of say, "Listen, my job is to help you. And if I thought surgery would help you, I would do it. But let's try some other things first, because number one, I can't see what I'd be operating on. And so I could actually add to your symptoms and make your quality of life worse. And I don't want you to leave with me having made your quality of life worse. There may be some non-surgical options we have." And then I always tell them, "Listen, leave the scans with me. I'll go over with my radiology colleagues. I'll follow up with you. Let's try some other things first, and be willing to follow up, and just that you're there for them." But because it's easy to say, "Okay, this patient's not going to add to my OR schedule. Let's get them out and push them on somebody else." Try to not be dismissive. Try to give them the time. They are there. They are a customer with your time, asking for your medical expertise, not only to be lined up for surgery. And so take the time to sort of talk through it with them. Like Alex was saying, like be be so saying thanks for coming in, and like Alex was saying, like be appreciative that they're there, try to listen to them as best you can, and then try to gently tell them, listen, this is why I don't want to do it. I don't want to hurt you. I think you can go to the next. So the following week, the patient relations informs you that they've received a letter from the patient stating that they don't want to pay for the visit because you refuse to help them. If the hospital refuses to remove the charges, they're going to report you to the state medical board.
This is when I offer a second opinion and I say, good news. His name's Trevor Hackman. And he's 10 miles down the road.
He's an expert,
Oh,
an expert in your condition.
Just 10 miles away.
Just 10 miles away.
I mean, so I had a patient who was quite difficult. Actually fired one of my partners, who's wonderful surgeon, fired one of my partners, and that was originally a big red flag, right? And what we ended up doing was, it was a situation where this patient ended up calling the president of the hospital's office and making this big complaint. And I can't take credit for this. Thankfully, they have processes in place here for Vanderbilt. But I met with a patient relations person who was sort of like the neutral kind of advocate to also like protect me in the situation. And we had a big plan for how we were going to talk about it. And then met with the patient to understand what their expectations were, what we could and could not offer them, and where the issue was. And that was extremely helpful. And in this particular scenario, that patient who was quite willing to rattle their sabers, via email or a phone call, when they actually got in person, sort of was like, well, I kind of backed off, right? When they saw how seriously we were taking what they were saying.
Yeah. In this particular aspect, so first of all, if you did what Beth and Dan and Alex talked about in the first page, this person's not calling. If you're empathetic, if you thank for coming in, if you offer help, you're not going to get this. If you're dismissive, this is what's going to happen potentially. This is the one where the reason I put this on there is document. That clinic visit that you first saw them, document what you talked about, take the time to document the options that you offer them. You've probably heard this in other talks. You've got to document, because when it comes down to it, what you document is what you did. And so document a long paragraph. It may be painful because it's 11 o'clock at night and you're doing your clinic notes, but document the hell out of this clinic note about all the things you offered them and all the options and your logic behind it, because that will protect you. Number two, the next call you make is to risk management, and you tell them, here's the clinic note, here's what I did. And then you have risk get involved and say, listen, you saw a provider, and they remind the provider you're seeing them for the medical opinion, not for them to be a surgerist to operate on you. And you get risk involved as that buffer. As that goes to sort of, I think, so that's the biggest part of that, is to remind the fellows on the call, because they tend to know this, is you got to document, because those patients will burn you at the stake if you don't have the clinical documentation to prove what you did. But if you're empathetic up front, you document, then hopefully you're not calling risk. Go back one slide, Alex.
Yes.
I think. Yeah. So like we talked about before, motivation for the hostile demanding patient, ask why. Like, why are they being hostile? Like Alex was saying, are they, or Beth was saying, do they have underlying distrust? Are they scared? Like, think about that. And then avoid the power struggle. Legitimize their concerns. You don't want to get into a power struggle with the patient in the room. It's never going to end well for you. So legitimize their concerns and their suffering, but be consistent with your advice and your recommendations. You can't waffle. It's very easy to give them a script for narcotics because that's what they want, get them out of the door in 5 minutes, but that's just going to open the door for them doing it again. Don't enable them or engage in slander or talk about other providers. That's a red flag if they're doing it. And then, like we talked about before, set boundaries. So if you legitimize their concerns, you're consistent with your recommendations, you document them, and you don't enable and engage, that helps. And then, like we talked about in the other scenarios, if you can find a way to build rapport with them where they can see you as a human being and they can appear as a human being to you, that makes it a lot easier. Next slide. And then, like we talked about, offer other options, offer the ability to think about the imaging, offer other workup and treatment, I think either Dan or Beth said this, admit the limitations or failings that listen, you can't, like this, this may be outside my realm of expertise. We as surgeons like to fix things, and we as head and neck surgeons who have gone to ENT, which is a competitive program, are used to having the answers to everything. It's okay to say, I just don't know. And I'm sorry, I don't know. And I'm here to listen to you, offer second opinions, reassure them, like Dan was saying, that listen, I know you're suffering. I know this is what you're really bothered by this, but I don't see anything concerning. Like, I don't think I see a life-threatening condition. I understand your quality of life is frustrating and isn't great right now, but I don't see anything that's life-threatening. And so I think you have time to figure this out and sort of to try to legitimize that. And just for the fellows, remember the patient seeing you and paying you for your medical expertise, not so you order a test, not so you write a script, and not so you do surgery. They're seeing you for your medical expertise. And if your medical expertise says, I don't think there's anything wrong here and we need to try therapy, something else, that's why they're seeing you, and don't feel the pressure to do more.
That's great. That's really, really some seriously good advice. Well, we only have a few minutes left, so I'm going to do a quick fire with this last scenario. So the VIP patient, you're scheduled to see Mrs. Smith, whose real name is on one of the hospital buildings. You've already received emails from your department chair, the president of the hospital, and the director of development to alert you to the importance of this patient. She presents with a T1 tongue cancer. Quickly, starting with Trevor, how do you handle this visit differently? You have 30 seconds, and then I'm going to move on to Dan and then Beth.
I offer them an appointment in the clinic as I would anybody else, and I say I'm happy to help take care of them. And I also tell them, and I also ask them, like, who do you want to really be knowing about what we're taking care of? Because a lot of people have called me, but this is your private health information, and I'm happy to see you. We'll get you in to get and take care of. But I would do this for the person off the street. But I tell them I'm happy to get them in. We'll get them in for the next available appointment. I can add you on for clinic tomorrow, and we can go from there. And then I ask them sort of who am I talking to about this? Because a lot of people have called me.
Dan.
Yeah, I mean, I'm not as senior as Trevor down the road, so they probably all go to him. But you know, I try to treat these patients in the same way that I treat everybody else, and you know, I may see them first instead of the resident, but you know, in terms of how the visit plays out, I try to talk to him just like anybody else, and because I think at the end of the day, that's a lot of people in that position actually want that, and people might be advocating on their behalf, but they most of the people I've seen in that position are actually pretty down to earth and actually just want the same good care that you give to everybody else.
Beth, any thoughts on this?
Same, and honestly, I would really just echo two things: treating them very much the same way you would anybody else, and asking them who is okay to talk to, and sort of making sure that it's appropriate to disclose or not disclose things, because I think sometimes when it comes in through so many different channels, it may it may really be difficult to know who you can say even the smallest things to. So
yeah, that's a really, you know, particularly the VIPs, right? Their name is known, so a casual conversation, you know, could be a serious breach of HIPAA. And the biggest danger, I think, to VIP patients is doing it differently than you always do it. You know, excluding residents from the care, or changing your normal way, getting all caught up in the hype around them, as opposed to just being like, this is an objective patient, just like every other objective patient. I'm just treating them. This is just Mrs. Smith. This isn't, you know, the donor. So and out of respect for everyone's time, I'm just going to wrap up with one slide here, and just a little summary. So always try to do the right thing by your patient. If you make a decision that you hear this all the time, you know, in risk management, is if you're trying to do the right thing for the patient, that will always be justifiable no matter what you do. I think being empathetic is really critical, and seeking information and looking for other causes. These are things that we've heard from each of our panelists, as well as setting boundaries, which I didn't include on this list, but is really important. You know, it is, you have to maintain a professional decorum, and also importantly, maintain control of your own emotions during these encounters. You know, you get someone treating you like a jerk, and you might want to fight back, and don't, as hard as it might be at times, the instinct, the fight instinct. And then, of course, documenting difficult encounters is really critical, as Trevor doubled down on in the last talk, and avoid jousting, avoid slandering other physicians.
Alex, that made me think of one thing.
Yes.
The main control your emotions encounter for the fellows and everything. You've probably seen and heard about the people who have responded to patients' comments on Twitter or on. Do not respond if a patient writes a slanderous review of you or writes something. Do not get into an internet war with a patient. It will never end well for you. It never looks good for you. I think there was a doctor, I can't remember who it was, that somebody said something bad about him and he went back and fired back about the patient and went back and forth. Don't do it. Don't engage. It's not going to go well for you. Talk to risk patient relations about getting posts taken down, but you don't want to be out in social media battling with a patient over social media.
Yeah, that's a very good advice too. Well, thanks everyone. Thanks to the audience for your questions. This went fast. I will say on a personal note, the thing I love about these kind of things, but in particular this one, is I learned a ton. I had learned a bunch of great ideas. I came in with my own thoughts. Of course, we were all sort of aware of the scenarios ahead of time. And I had my ideas of how I was going to answer. And I learned a whole bunch from the three of you about other ways to think through these problems. So thank you for your time. Thanks everyone in the audience. And y'all have a wonderful evening. Take care.